Welcome to Health Issues Sunday. Can malaria mimic COVID-19? Is it possible to have the symptoms of COVID-19 and yet have malaria? How has COVID-19 affected the world's health system and diagnosis of other infectious diseases? Well, to find out more about this, keep watching the video, and don't forget to subscribe and hit that notification bell for more videos. What is malaria? Malaria, sometimes called the king of diseases, is caused by protozoan parasites of the genus Plasmodium. Malaria is the most important infectious disease in tropical and subtropical regions, and continues to be a major global health problem. The number of malaria cases worldwide seems to be increasing, due to increasing transmission risk in areas where malaria control has declined, the increasing prevalence of drug-resistant strains of parasites, and in a relatively few cases, massive increases in international travel and migration. The unprecedented global coronavirus disease, COVID-19, pandemic caused by SARS-CoV-2 has rapidly spread to all continents. As of May 18, 2020, there have been 4,890,863 confirmed COVID-19 cases reported to the WHO, with 320,130 deaths. In comparison, the WHO malaria report indicates that there were an estimated 228 million cases and 405,000 deaths due to malaria globally in 2018, majority of which were from the Africa region. How has COVID-19 affected the world health system? Well, the ongoing COVID-19 pandemic places an extra burden on health systems worldwide, and especially in countries with fragile health systems. Many countries, particularly in sub-Saharan Africa, which accounts for more than 90% of global malaria cases and deaths, are facing a double challenge of protecting their citizens against existing and emerging threats to public health. Here are 3 ways how malaria can mimic COVID-19 and thus make diagnosis difficult. Number 1. Malaria shares some of the highly recognizable symptoms with COVID-19, such as fever, difficulty in breathing, fatigue, and headaches of acute onset. Thus, a malaria case may be misclassified as COVID-19 if symptoms alone are used to define a case during this emergency period, and vice versa. Number 2. Malaria symptoms appear within 10 to 15 days after an infective bite. Multi-organ failure is common in severe cases among adults, while respiratory distress is also expected in children with malaria, mimicking what is usually reported in patients with COVID-19. Number 3. Human travel history is also a significant consideration, like with COVID-19, when screening for a suspected case of malaria, as well as a means of curbing transmission. Also, both COVID-19 and malaria-infected individuals may be asymptomatic for a long time while transmitting the infections through their respective modes. Globally, all countries are at very high risk of COVID-19, while half of the world is at risk of malaria, with sub-Saharan countries bearing the brunt of malaria cases and deaths, while Southeast Asia remain at high risk of both malaria and COVID-19. Thus, COVID-19 and malaria converge symptomatically and geographically in most WHO regions. How has this overlap affected the correct diagnosis of both diseases? Currently, it is expected that a high index of suspicion is skewed towards COVID-19 given the alertness at community, health center, country, regional and global level. In addition, another challenge is that people with fever may preferentially get tested for COVID-19 and sent home due to a negative result, and conversely, febrile patients may get tested for malaria when they may in fact have COVID-19 infection. The other case scenario is that patients may have malaria and COVID-19 co-infection, and diagnosis and treatment of one may lead to missing the other. A single case of COVID-19 has the potential to transmit up to 3.58 susceptible individuals. Untreated malaria, on the other hand, has the potential to cause further community infections, which in turn continues to be a significant source of illness and deaths globally. Thus, undetected COVID-19 virus and malaria parasite infections pose an immediate health challenge to the individual and public health consequences for the community. Furthermore, there is concern that limited mobility and lockdowns will interrupt the supply of malaria drugs. There is no specific treatment available for COVID-19. Host-directed therapies, including repurposed drugs such as antiretrovirals, zinc, nutraceuticals, chloroquine, hydroxychloroquine, are being considered. Countries are struggling to meet the testing demand for COVID-19, while the malaria test kits are widely available at each point of care, including the community level. There is need, therefore, for enhanced sensitization on the potential of COVID-19 malaria co-infections, and further guidance to clinicians on the importance of testing for other causes of illness, more so, in this period when there is much emphasis to early detect and isolate COVID-19 in an effort to contain further spread of the disease. So how can we definitely know which disease is at play? The definitive way to correctly identify the underlying infectious etiology is through laboratory investigation. Therefore, availability of appropriate diagnostic capacity is essential for accurate surveillance and clinical management of cases. A case of COVID-19 is deemed confirmed based on a positive laboratory test result for SARS-CoV-2 virus infection regardless of symptoms. However, the current screening approaches for COVID-19 are likely to miss approximately 50% of the infected cases, even in countries with good health systems and available diagnostic capacities. On the other hand, the need for effective and practical diagnostics for global malaria control is increasing, since effective diagnosis reduces both complications and mortality from malaria. Conventional microscopic examination of peripheral thick and thin blood smears remains the gold standard for malaria diagnosis. Other methods of malarial diagnosis include RDTs, serological tests, molecular biological techniques, and clinical diagnosis. How must we approach this situation then? Since malaria tests are relatively more available, it can be recommended that health workers perform rapid tests for malaria as they screen for COVID-19. This presents an opportunity to respond to two infectious diseases timely and reduce unnecessary morbidity and deaths. By rapidly ruling out malaria, the health workers can focus on the true cause of illness, and administer appropriate management. This issue is more relevant for travelers and people in malaria-endemic countries, as this is a season when malaria transmission is at its peak in sub-Saharan Africa. On an operational level, countries should look at how services for malaria and COVID-19 are organized so as to efficiently use the available resources. For instance, malaria supplies could be moved to the laboratories, or sites where the COVID-19 testing is being done so as to reduce missed opportunities for malaria testing, as some patients may be lost if they are declared COVID-19 negative, while in fact they may be malaria positive. How are you coping with the pandemic right now? Let us know in the comments below. The references and studies used in this video are added in the description below. If you find this video helpful, don't forget to like and share with those who might benefit from it. Thank you for watching, and see you in the next video.